welcome to Medcussion with Haider, and today the topic of our focus and our discussion is Tocillizumab. So what is Tocillizumab? It is actually interleukin 6 receptor blocker, and it has been showing marvelous results in the severe and critically ill patients with COVID-19. So let us see more. Let us explore more about this drug, that it is actually immunosuppressive drug which is being used for rheumatoid arthritis and for the severe juvenile idiopathic arthritis in children. That why there is arthritis, we don't know the cause, but still this drug is used, and it has achieved marvelous results, marvelous peaks of good results in that. And it is what the composition of this drug is. It is actually human monoclonal antibody. In the previous lectures I told you that how this monoclonal antibody is made, and what is actually antibody and what is antigen also. So what is actually interleukin 6? First we have to see that, we have to go into that interleukin 6, it is a cytokine, or you can say a chemokine, which stimulates the acute phase protein production. You can from the first aid you can see that what are the interleukins and what are the types and what are their uses in our body and how they are produced. So we have chosen interleukin 6 because it is the evidence which is in the description below, that which shows that interleukin 6 promotes the more inflammation, more cytokine storm, more immune response of our own cells towards our tissue damage of the body. So we have to first see that, and for the evidence, there is no showing that interleukin 6 it is phytotoxic drug or it is not used in pregnancy. There is no evidence of abortions in induced by the interleukin 6 receptor blocker in pregnant women, but there is some evidence which shows that in pregnant animals, when it was used, it showed that it causes the spontaneous abortion. So we have to be careful about that, but still the studies are going on. Now we see that how interleukin and where the interleukin is produced. So interleukin 6 is produced by a chromosome number 7 on the gene, on the short hand of the X chromosome, and it is the interleukin which promotes the acute phase protein production, which in the chronic inflammatory or long-lasting inflammatory diseases. Number 1, it produces the CRP, C-reactive proteins from the liver, which is known to have been used in a good diagnostic tool in the long-lasting inflammatory diseases. Number 2, there is serum amyloid, there is, you can say, haptoglobin, there is alpha-1 anti-chymotrypsin. So this is what it do. These are all the acute phase proteins. Number 2 is it decreases the zinc importers, it increases the zinc importers. It means that it increases the zinc importers in our body, which leads to the increased amount of zinc in our body, which is always a helpful thing, which the evidence shows for the treatment of COVID-19 infected patients. And number 3, it causes the decreased iron intake. It decreases the iron transporters in our GIT, iron importers, which leads to decrease in the iron in our body, which can lead to anemia. Of course, it leads to anemia. So it has been known from the evidence that anemia in children, or anemia in acute, or you can say a long-lasting, a chronic inflammatory disease, is due to interleukin 6. So it causes the decrease in iron, which leads to anemia in chronic inflammatory disease. So contraindication of this drug, that shows that it is not allowed to use for the latent tuberculosis. Number 2 is in acute infections. So we are not using this drug in acute COVID infection also. Like if you have acute COVID infection, we cannot use this drug. It is also severely contraindicated. But by the evidence, it shows that for the severe critical patients on the ventilator from 40 to 50 days spending in the ICU, they used this drug on them, and which shows the therapeutic effects of it. And the second thing is that we have to discuss the adverse effects of this drug. The adverse effects, some are common, some are uncommon. The most common side effects caused by this drug are headache, it promotes the upper respiratory tract infection more than 10%. It is the most common side effect, but we can handle that with the symptomatic therapeutics. We can use some other therapeutic drugs which reduces that, and if we don't have to use this drug for a chronic or a long period, because it has some severe side effects it causes. So in 5% of patients it develop hypertension, 5% of patients develops the increased ALT level, liver damage. So we don't have to use this for a long period, so to minimize the side effects. And increases the total cholesterol level, because whenever the liver functioning is a bit distorted, it causes the increase in cholesterol level. And it is not used in long term in COVID-19 patients, as I have always mentioned it there. And the less common side effects are nasopharyngitis, there is dizziness, you know what is mouth ulcers, it causes the mouth ulcers also, and mild rashes in approximately 1% of patients, or you can say 0.26%, according to the evidence, which shows that out of 400 people, 1% or 1 person develop these type of uncommon symptoms and may develop GIT perforation or GIT ulcers. So we have to see that from where in our body interleukin 6 is produced. Interleukin 6 is produced by the macrophages, by the adipocytes. So that's why in the obese patients, if there is obesity, you have increased number of adipocytes. The increased number of adipocytes leads to increased production of interleukin 6 and acute phase protein production, which leads to more inflammation also. So epithelial cells, remember epithelium cells, our whole respiratory tract, you know, it consists of epithelial cells, mesenchymal cells. And what the interleukin 6 do in our body, it imbalance the immune cells. We have to see the pathogenesis, but I again don't want to go into the detail of all the pathogenesis, because it has to be related with the immunology. So I think I have given a good guidance to you that you can study that further if you are a medical student, but for the overall guidance I can tell you that it imbalances the immune cells. The interleukin 6, we are not blocking the interleukin 6 production, we are blocking its action. That we have to block interleukin 6 receptor. So Tocillizumab is interleukin 6 receptor blocker. So by blocking that receptor, it leads to the blockage of the differentiation of CD4 cells into T helper 8 cells. It blocks the differentiation of naive T cells into CD17 cells, which are T17 cells. It blocks the B cell differentiation and it blocks the neutrophils, which comes to the acute infection area. So it blocks all that, which leads to decrease cytokine storm and decrease amount of the damage which it is already occurring to your body, which is already being done to your body. So we have to see the statistics which are being used. We have a whole table, the link is in the description below, and this all study we have got that from France. And we can see that the T helper 8 cells, they are cytotoxic T cells. They produces perforins. Perforins are the proteins, or you can say the enzymes which leads to the perforation of our own cells which are infected with COVID. So it do perforins, it releases granzymes which go into the cells and say them that you have to do a programmed cell death, which is known as apoptosis. So that's why. And remember, the 80% of dead neutrophils are in the pus. Whenever you see a pus, the whitish or yellowish, especially yellowish fluid gushing out of your wounds or abscess, in it, the main composition is the dead neutrophils. So dead neutrophils always comes into the acute infection area and produces pus, which has also been seen in COVID-19 patients. So we have a statistics of the therapeutic results in the patients. So there are two dosages, 200 milligram or 400 milligram of Tocillizumab in the patients. There is placebo, there is 200 milligram, there is 400 milligram. So the patient who are dead or on the ventilator, 55% were dead due to placebo, 46% were died which were being used with 200 mg and 400 mg 32%. So there is a drastically decreased amount of patients die by the 400 milligram, or not due to it but actually due to the COVID. So only the died patient, if we see, 27% died. They were not using any type of drug like Tocillizumab, and 36% died due to 200 milligram, like with the 200 milligram dosage intake, and 23% died of 400 milligram therapeutic dose which they were being given. So it's also a decrease of 5% in the died people, death rates of the people with COVID-19 in the therapeutic administration of 400 milligram. And those patients who were on ventilator, they were like 27% without using this drug, 10% with 200 milligram and 9% with 400 milligram. They recovered from that. So there is also good clinical improvement seen in the patients. 41% were improved who were not using any drug. 51% were improved clinically who were using 200 milligram, and 59% were improved who were using 400 milligram. Discharged patients, those who were discharged, 41% were discharged by using no type of Tocillizumab or any monoclonal antibody drug or interleukin-6 receptor blocker. 39% of the patients were discharged who were having a therapeutic administration of this 200 milligram dose, and 53% were discharged from the hospital who were using 400 milligram of Tocillizumab. So still more studies are going on in France, and we have shared the evidence and description links below. So you can study that also. You can see the basic concepts of immunology if you are new to us and you are new to the discussions. I hope I could be able to explain you on the ground level, on the detail level of this. But for that we have to be more appreciative to each other so that we can do mutual cooperation. So if you like this, then kindly share and subscribe and remain with us. See you next time in the next video on the next topic. And you can also suggest that what topic should be next, or what drug or anything like that should be next for our Medcussions. The increased amount of comments, majority is authority, will be appreciated a lot. Thanks a lot.